Hello guys, today we're going to be talking about sepsis and components of the medical exam. We're also going to be discussing acid-base balance and capnography and how we can incorporate that into our medical exams and assessments and relate it to sepsis. The objectives for this lecture are going to be reviewing the components of the medical exam. We're going to discuss pathophysiology and shock of sepsis. I do have some slides from the Colorado Hospital Association in this training, so shout out to them. They'll be listed in the sources. And then we're going to review sepsis criteria and evaluation of sepsis patients. Notice this is in the BLS objectives because a lot of this could be done at the BLS level. Next, we're going to discuss the physiology of acid-base balance and go over capnography and assessment of patients with metabolic and respiratory disorders and discuss ALS intervention for sepsis. Alright, so I'm going to be going over components of the medical exam. Here I have listed 3 approaches that we probably use most often here at WFRD, but by no means is this an all-inclusive list. The first is going to be the focused approach, and this is best for specific chief complaints without altered mental status. So we're really going to be honing in on the reason why 911 was activated and brought us to the scene. So think of an isolated injury where the kinematics of that trauma don't really suggest anything else is going on. This could just be like a laceration to the hand, if a patient was cutting some produce with a knife. Another example would be like a behavioral emergency where the patient's having suicidal ideations, but they really don't have any intent on carrying it out, and we don't have a reason to suspect that they overdosed on anything. They just want to go to the hospital and get some help. All right, next we're going to talk about a systemic approach. And again, this is probably good for patients without altered mental status. However, that doesn't necessarily need to be the case. When I think of a systemic approach, the first thing that comes to my mind would be a patient with syncope. We're not just going to be asking them about how they fell and if they're still feeling dizzy or if they hurt themselves, but we're really going to be doing a systemic evaluation, more specifically for this patient on their cardiovascular system. We're going to be doing an EKG to make sure that their heart is looking okay. Potentially we're going to be doing orthostatic vital signs. So again, we're really focusing in on an entire body system that could be causing her symptoms. Another common example would be a neuro exam when we're considering a stroke. We're not just asking them about their symptoms, but we're doing a neuro exam to find any abnormalities. Okay, and finally we have the head-to-toe exam, and this is what we're really going to be focusing on for this training. Included in this training, I have a PDF of the National Registry of ENT's head-to-toe exam checklist, and that's going to be the hands-on portion of this. We're just going to be going through head-to-toe, looking at the checklist, and seeing kind of what they want us to be doing. So this is, again, the most comprehensive approach, and this is going to be really good for patients that are altered, unresponsive, or if we know something's going on but we can't quite figure it out. Just this head-to-toe approach is really going to break everything down for us and help us identify anything that we may have potentially missed otherwise. So in addition to the hands-on portion of the medical assessment, we also have the history-taking portion. We're all familiar with the OPQRST acronym. It stands for onset, provocation, quality, radiation, severity, and time. Onset's not to be confused with time. It's what the patient was doing when they had the onset of symptoms. So a lot of times for a chest pain, we want to know if they were doing strenuous activity versus just sitting on the couch or lying in bed. The difference being if the onset is with strenuous activity and it's relieved with rest, that's going to be a little less concerning than someone just sitting on the couch and all of a sudden they have this sudden onset of chest pain. After onset, we have provocation. Provocation is what makes the pain worse, and we really want to get specific with this. It could be being in a certain position, makes their pain worse, or if they're having abdominal pain. Not only would it be, oh yeah, it's tender upon palpation, but is it tender upon downwards pressure or is it tender upon releasing pressure? If they're having chest pain, if they take a deep breath, what does that pain feel like? Is that pain a constant, dull, heavy pain? Or do they have sharp pains when they take a deep breath? Because if they do, that can be indicative of pleuritis or potentially a strained intercostal muscle. Palliating factors also falls under P, and it's the opposite of provocation, is what makes it feel better, like a position of comfort or maybe a cold compress on their head if they're having, a headache or something like that. Quality is going to be how the patient describes the pain. Is it sharp or throbbing, stabbing, or is it more like dull and heavy, or is it burning? This is really going to be descriptive words that we're looking for. It's important to ask these questions because how they describe the pain can kind of cue us into where the pain is coming from. For example, if it's sharp and stabbing and they can really pinpoint where it's at, it's more likely like a somatic pain, and this is pain that originates from the skin, the muscles, the bones, or the joints. These areas are heavily innervated with nerves, so they can really pinpoint that pain. Where another type of pain that we encounter very often is going to be visceral pain. Visceral pain usually has poor localization, and it's like diffuse in nature, and it's really hard for them to pinpoint it. And this pain is coming from the organs, and there's really not a whole lot of very specific innervation to the organs that can help them pinpoint it to that specific spot. And while the organs are poorly innervated, they really give us non-specific pain qualifiers, they also are notorious for referred or radiating pain. So these organs, their neural pathways, are associated with other areas of the body, which is why we see things like referred pain, like for the spleen or the liver, we might have Kerr's or Murphy's sign. Or it's why, for chest pain, it's notorious for radiating down the left arm. It's because these neural pathways that innervate, the organs also innervate these other locations of the body. So that's why it's very important that we ask these types of questions, because it can really cue us into, if they're having pain in their shoulder, maybe something's going on with an abdominal organ. And now that the patient has qualified their pain, what we really want them to do is quantify their pain. So if the patient is alert and they're oriented and they can answer our questions appropriately, we can use a scale of 1 to 10, with 10 being the worst amount of pain that they ever had. If they're not very verbal, or if they're altered, or they're just not able to answer questions, we can use the Wong-Baker Faces scale. So S stands for severity. And finally, we're at time. We really want to hone in how long their symptoms have been going on. For strokes, this is very important. For chest pain, it's relatively important. So has it been a matter of minutes? Has it been a matter of hours or days? If this is a chronic condition that they have, and they say, I always have this going on, well, that doesn't really help us for time. So what we want to ask is, well, what caused you to call 911 now? What changed? And that can be our new onset of symptoms, and we can use that for time. However, it is important that we relay that this is a chronic condition, in our narrative and when we call the hospital. After we go through OPQRST, we move on to sample. And really, you can interchange these acronyms. You don't have to do OPQRST first or sample first, or you don't have to necessarily go through all of one before you hit the other. Once you get comfortable with this, you can start to break it up as you feel pertinent, for the assessment of your patient. For sample, the S stands for signs and symptoms. Signs are going to be quantifiable through a medical examination. So we're looking at high blood pressure, for example, for a sign. We're looking at low SpO2. Symptoms are going to be things that we really can't, evaluate through an assessment. Symptoms are going to be their chief complaint, how they tell us they feel, how they qualify and quantify their pain. Allergies, we want to know if they have any allergies before we give any medications, or if potentially they've been exposed to any of their allergies, which could be a contributor to the reason why we're called out. Medications are important for us to gather because they could be an indicator of the patient's past medical history, especially if we have an unreliable historian in the patient or an unreliable historian as a family member or a care provider. A lot of times if our patient's altered or unresponsive, the medications might be the only hint of a medical history of what's going on. And again, these medications could potentially be, a contributing factor to the reason why we're out there. Finally, we have last intake and events leading to illness. Last intake is often omitted, but it often is pertinent, for patients having GI issues or nausea, vomiting. We want to know if they ate anything that triggered this response, or if they have any food allergies that potentially could be contributing to the response. So last intake is important, and especially if they're going to be doing medical interventions at the hospital, potentially surgical interventions. The last oral intake is going to be important for the anesthesiologist if they need to put them under sedation. And finally, we have events leading to illness. And this is everything that's just leading up to the moment that they called us. So a lot of times, this could be as simple as I was cutting some produce and I cut my hand, and now here we are. But for these more chronic conditions, really asking a history of these specific complaints and how it built up over time can really cue us into what's going on, especially if we got a vague onset of symptoms or a vague chief complaint. If we really ask good historical questions, we can begin to put the pieces together. Okay, so let's discuss the head-to-toe exam a little bit more. We often do these head-to-toe exams in our trauma assessments, whether it be a rapid trauma or a primary, assessment on our trauma patient, but it's rarely performed in medical exams. But it's really crucial that we do these things, especially when we have altered patients or unresponsive patients and we don't know what's going on. So really, this can be performed in the exact same way as we do a trauma exam, from head to toe. And we are going to be looking for decap BTLS. Maybe we're not suspecting an injury, that just recently occurred, but maybe we find an injury that's leading, to the symptoms that we're seeing now. For example, if we're examining their head and they have a contusion on the back of their head, maybe they fell a couple days ago and now we're showing signs and symptoms of increased intracranial pressure. Or maybe they have contusions or lacerations, on their body that led to an injury, and maybe that laceration became infected and our patient is septic now. So in addition to decap BTLS, we also want to look for other things, and we're going to be doing a systemic approach, of their body. We're going to be looking for pacemakers or defibrillators, medication patches or medical tags to alert us to a past medical history. Maybe they have a fentanyl patch and they're overdosing, or maybe they have a nitro patch and that's causing their blood pressure to tank. We're also going to be looking for other potential sources of infection, like feeding tubes. They could have a J tube or a G tube, or potentially urinary catheters. Those are huge for infections. So we're looking for things like that, but also ulcers. Do they have a bed sore that's infected? We're going to be palpating, pulses. Do they have asymmetrical pulses, or all their pulses in all their extremities, strong and equal? Abnormal pupillary response. Do they have jaundice of the eye, or potentially jaundice in their mucous membranes? Do they have any pulsating masses or like rigidity or distension, in their abdominal area? All these things are going to cue us into any potential abnormalities that are going on. And if our patient is unresponsive and they can't talk to us, this is really the only source of information that we have, to affect a positive change and figure out what's going on and relay that to the hospital when we transport. So doing a thorough medical exam and history is important because it's going to alert us to anything that may be going on, but it's especially important if it's going to cue us into the possibility that our patient may be septic. Sepsis is very hard to identify in the field because the signs and symptoms are very common to some of the other things that we see. So the signs and symptoms of sepsis are fever, but they don't necessarily have to be febrile. They can even have a low temperature or normal body temperature, tachycardia, and elevated respiratory rate. Very ambiguous. So that thorough medical examination could cue us into any potential sources of infection. And probably the most important thing that we can do is initiate a septic alert at the hospital and start an IV and start some intravenous fluids to get that going. As you can see, if you look at the picture here, that for every hour that there is a delay in antibiotics, the mortality rate increases significantly. This black line, as time goes on, that is the decreased survivability. So, what is sepsis? Sepsis is a systemic inflammatory response due to an infection within the body. Another example of a systemic inflammatory response is anaphylaxis due to an allergen, and we all know how critical it is in recognizing anaphylaxis and treating it. Same thing for sepsis. So, in a normal response to an infection, we have our typical signs of inflammation. So we have swelling, we have redness at the site, it's tender or painful to the touch, and it could be hot. So this is the body's normal inflammatory and coagulation response, and it keeps it localized and it eliminates the pathogen from the body. Sepsis is when that pathogen, that infection, cannot be controlled at the source, and it becomes systemic throughout the body. So, in continuing our analogy with anaphylaxis, sepsis, if unrecognized, can very quickly progress to death. The inflammatory and coagulation response is rapid and widespread, and it causes a dysregulated response. The body's reaction to the pathogen may overwhelm all the body's systems, and that's going to lead to organ failure and eventually multiple organ dysfunction syndrome, otherwise known as MODS, and that's pretty much a death sentence. So sepsis can really impact someone if they have a weakened immune system because they are more prone to getting the infection. However, once you do have the infection, it also exposes people at risk if they have a very strong immune system. Again, because this is the inflammatory response that is killing our patients. It's not necessarily the infection itself. We treat these patients with antibiotics because if we can get rid of the actual infection, that's going to stop the inflammatory response. But that's also why you see drugs like immunosuppressants given to help tamper down, that immune response, because ultimately it's the immune response that kills our patients. Sepsis is a worldwide problem, and it is a problem here in the United States, affecting an estimated 30 million adults and children each year, resulting in potentially 6 million deaths annually. In the United States, it accounts for only approximately 20% of U.S. hospital admissions, but it is a factor in over 50% of U.S. hospital deaths. It is also one of the leading causes of U.S. hospital readmissions at 20%. And even though the mortality rate is decreasing, it still remains above 25%. So that is pretty significant if 1 in 4 people getting severe sepsis are dying. So what are causes of infections? Well, obviously it's going to be a pathogen, but we have different types of pathogens. The most common are going to be bacterial infections. However, fungal, parasitic, or viral infections are also common in causing sepsis. The infection really can originate from anywhere in the body, and it could cause organ damage to any system in the body. It just all depends on how that infection spreads throughout. And approximately 1/3 of all cases, the cause of sepsis is unknown. Even though sepsis can originate from any point in the body, some of the most common places for it to come from are from a lung infection, a UTI, a gut infection, or a skin infection. So especially if the patient has a history of pneumonia, where they were recently diagnosed with it and all of a sudden they're altered and just something doesn't seem right, right off the bat you should be suspicious of sepsis. Even if they don't have a known history of pneumonia, it's very important that we listen to lung sounds. It's very probable or possible that we could hear rhonchi, in an area of their lungs that could be indicative of pneumonia. And if they're altered, we now have a probable source of infection, and we might meet SIRS criteria for us to call a septic alert. UTIs, very common, especially in the female population. It's very important that we ask our patients, the quality of their urination. Is it frequent urination, more so than normal? Is it cloudy in color? Do they have painful urination, or does it smell malodorous? Is it worse than normal? That's very important for us to know, because UTI accounts for approximately 25% of all sepsis cases. Another 11% is the gut infection, which I never would have thought of, but apparently it's very common. And skin infections, whether it be from laceration or if they have just chronic skin conditions that lead to skin infections. Who is at risk to develop sepsis? Well, anyone really is at risk of developing sepsis, but certain populations are more prone to it than others. Age is one of the obvious ones. The elderly account for 60 to 85% of all cases of severe sepsis. Gender is another factor. We talked about UTIs in the last slide. Females are more prone to getting UTIs, so that's going to lead to an increased rate of infections, especially by UTIs in the female population. But another thing to consider is that males tend to have COPD more so than females, and COPD can lead to increased rates of pneumonia, which can also lead to an increased rate in sepsis. So we also have comorbidities. So we talked about COPD. But I also want you to think about diabetes. Do they have diabetic ulcers in their legs because of poor vasculature and decreased ability for any wounds to heal? That's going to lead to increased infections. Also, cancer or AIDS or any immunosuppression disease. People with cancer or AIDS, they have weakened immune systems, so they're going to naturally be exposed to infections just like anybody else, but that could lead to sepsis. So that's the immunosuppression. And then exposure risk, community acquired, people living in nursing homes or people in the hospital. Those are all things healthcare acquired. Invasive devices, secondary infections, and skin breakdown. Hospital acquired pneumonia is a common thing, especially after intubation. So how many of those interventions are leading to, sepsis cases? So the progression of sepsis begins with SIRS, and SIRS stands for Systemic Inflammatory Response Syndrome. In SIRS, the presence of SIRS does not necessarily mean that the patient has an infection, because we talked about other sources of inflammatory response such as anaphylaxis. So SIRS criteria, in order to qualify for it, you need at least two of the qualifying factors, and the temperature, it needs to be greater than 38 degrees Celsius, which is 100.4 degrees Fahrenheit, or less than 36 degrees Celsius, which is less than 96.8 degrees Fahrenheit. We also need to have an elevated heart rate above 90. For some patients, that might be normal. An elevated respiratory rate above 20. For some patients, that might be normal. A respiratory rate of 20, 21, might be pretty insignificant for some of our chronic COPDers. And finally, they have the partial arterial concentration of CO2, and that is less than 32. We don't have a direct way of measuring PaCO2. However, we do have an indirect way, and that is our end-tidal CO2. So the end-tidal CO2 is typically 2 to 5 points less than the PaCO2. So if we have an end-tidal CO2 that's around 27, 28, they're right at that 32 mark potentially. So after SIRS, we move on to sepsis. And sepsis is the presence of at least two of the qualifying SIRS criteria plus a known or probable source of infection. And it's important that we identify sepsis at this stage, because this is where we can really affect the most positive change. Because as they begin to progress up the scale here, it's going to be harder and harder to treat them, and their survivability just decreases. So it's important that we do our medical examinations and identify any potential sources of infection. And it's also important that we ask them these very specific questions to maybe help us identify sources of infection. So again, sepsis is the presence of SIRS plus infection. Moving on from sepsis, we have severe sepsis. And severe sepsis is the presence of sepsis plus end organ damage. So some of the things that we can assess for end organ damage is a decrease in mental status. So do they have a change in LOC or a Glasgow of less than 12 without any explainable causes? Another thing would be a drop in their blood pressure. Is their systolic less than 90, or did they have a drop of greater than 40 from their normal? Or if they have a mean arterial pressure less than 65. If they have a mean arterial pressure less than 65, they're most likely going to be altered, because 65 is about the baseline minimum that's required to perfuse your brain. So if they're not perfusing their brain, they're going to have a drop in their level of consciousness and their Glasgow coma score. So all these things are kind of interrelated. Respiratory, are they requiring CPAP for no reason, or do we need to ventilate them? Do we need to intubate them? These are declines in the respiratory system. All the other things on this slide we can't really assess for in the field, but for renal, like do they have decreased urination? That could be indicative of renal failure damage because of end organ failure due to sepsis. Moving from sepsis, we're going to go into septic shock. And septic shock is going to be severe sepsis plus the patient's hypotension being unresponsive to treatment. So they're just going to have chronically low blood pressure. So severe sepsis could be diagnosed with a lactate greater than 4, but we do not have lactate monitors. That is something that is available, but it's not widely available, and it's relatively expensive to do. So we need to rely on our assessment and medical exam. and our vital signs that we can actually do. So septic shock is considered a distributive shock. It's caused by a cytokine release, which leads to a large-scale inflammatory response. Again, we're talking about inflammatory responses, systemically. So we have massive vasodilation, we have increased capillary permeability, we have decreased systemic vascular resistance. What does that sound like? That sounds a lot like anaphylaxis to me, because it's the same thing. However, we're also going to form blood clots in the microvasculature, and we're going to have hypotension, reducing our tissue perfusion, which is going to cause tissue hypoxia, which is going to lead to shock, because shock ultimately is decreased perfusion at the cellular level. So ultimately, if sepsis is not treated, it's going to lead to MODS, which stands for multiple organ dysfunction syndrome. So this is essentially the failure of any one of our organ systems. We're talking respiratory failure, liver failure, kidney failure, heart failure, gut permeability. That sounds awful. DIC, disseminated intravascular coagulation. You're essentially clotting everywhere and you're bleeding out because you run out of clotting factors. You're going to have altered mental status, and that's ultimately all this stuff is going to lead to brain death. Once we go into multiple organ failure, it's very hard to reverse it. So that's why it's super, super important that we recognize sepsis, at the earliest stage possible. If we have SIRS criteria, we really should be honing in on our medical evaluation to figure out if there's any sepsis. So here are the initial medical care special considerations for sepsis. We need to rapidly assess for risk factors or signs and symptoms suggesting infection and a infection source. They want us to place the patient on end-tidal CO2. If they have levels below 31, they want us to move on and assess their QSOFA. So QSOFA is the quick sequential sepsis-related organ failure assessment criteria. So if they have a Glasgow of less than 15 if they're normally alert and oriented, or if they have a Glasgow reduction of 1 or more points below the patient's baseline. Another one of the criteria is a respiratory rate above 22, systolic blood pressure less than 100, and they only need to meet 2 of these criteria. So a Glasgow less than 15 or 1 less than their normal baseline, an elevated respiratory rate, and hypotension. If they meet 2 of these, they meet the QSOFA criteria. They also want us to trend their pulse pressures. The normal pulse pressure is 30 to 50. So pulse pressure, if any of you guys don't know, if they have a blood pressure of 120 over 80, the pulse pressure is the difference between the systolic and the diastolic. So pulse pressure for that blood pressure would be 40. And a mean arterial pressure. And a mean arterial pressure of normal is between 70 and 110. There's a calculation for the mean arterial pressure. I believe our monitors do display it. I'm not 100% on that. But if you guys have questions on how to calculate a map, just email me. Finally, we're going to assess signs and symptoms of fluid depletion. We're going to do orthostatic vital sign changes if they're not hypotensive. So we talked about this in our cardiovascular systemic, examination. Have the patient sit down, get a blood pressure, and if possible, sit them up, stand them up, and see if their blood pressure changes. If they can't stand up, we can do this with them lying down, get a blood pressure, and then sit them up. Do they have poor skin turgor? Is their skin tenting? Do they have dry mucosa? And we're going to initiate fluids on these patients. And then also we need to assess their glucose. These patients are going to have a hyperglycemia. All shock states tend to lead to an increased glucose level. So they further divide sepsis into a warm stage and a cold stage. So the warm stage they're saying is between 6 and 24 hours. They're going to have an elevated respiratory rate, and they're going to have a hyperdynamic phase with high cardiac output. So what I like to think about this is if we're giving them fluid boluses, they're going to be responding pretty dynamically to those boluses. But they are going to have a systolic blood pressure of 25% less than normal. Most likely, we're not going to know what their normal is, but keep that in mind. That's an assessment criteria that maybe we can figure out. They're going to have a fever. They're going to present with vasodilation. Their skin's going to be hot, dry, and flushed. Vasodilation and hot, flushed skin, those are things that I would expect to see for an anaphylactic reaction. So again, a lot of similarities here. After the warm stage, they're going to move on to the cold stage, and this is an ominous late sign. So here they're definitely going to be altered, and they may be afebrile. They may be the opposite of having a fever with a temperature less than 96.8 degrees. Their skin's going to be cold and mottling. And again, they're going to have elevated heart rate and respiratory rate and profound hypotension. So after those boluses, we're probably not going to be getting their blood pressure back up. So this would be a septic shock here. So indicators suggesting infection: fever, warm skin, diarrhea, fatigue, altered mental status, dysuria. So that's going to be foul smelling or cloudy urine or frequent urination, urination that is not normal. Cough, dyspnea, so shortness of breath, local redness, warmth, swelling at unhealed wounds, and a sore throat or an earache. If they're septic, we need to suspect an infection. They need to have an end tidal of less than 31 and meet 2 Q-SOFA criteria. If they meet this, then we must contact medical control with a sepsis alert. And we're going to be giving them 200 milliliter boluses to achieve a systolic blood pressure greater than 100. So they're defining septic shock as sepsis plus a systolic blood pressure of less than 90 or a mean arterial pressure of less than 65. You can have a mean arterial pressure of less than 65 with a systolic blood pressure above 90, or hypotensive for the patient, so 40 points below their baseline. So this is where our medical history and examination is very important. If we have a patient with hypertension and their blood pressure is normally 160 over 90, that's not a great blood pressure. And now we take it is 118 over 70, we might say, hey Bob, you're doing pretty good. But really they're 40 points below their baseline, and that should be a huge cause for concern for us. Also, end tidal of less than 25, they're stating is associated with a lactate above 4. Lactate above 4 is associated with septic shock, so end tidal is also another very useful diagnostic tool that we have in our tool belt. So after we call medical control with a sepsis alert, we're going to be doing our normal saline 200 milliliter boluses in rapid succession. We're going to be reevaluating the patient after each bolus, but we're going to continue to do that up to a liter. However, if their hypotension persists after 500 milliliters, we're going to add our dopamine. Our dopamine, we're going to start at the beta dose of 5 micrograms per kilogram, and we're going to titrate it up as needed to 10 micrograms per kilogram per minute. So if you don't remember how to achieve the dopamine drip rate, you take their weight in pounds. So going with a 180-pound patient, we're going to take 180 and we're going to drop off the 0 at the end. We're going to subtract 2, which gives us 16. 16 drops a minute is going to be our beta dose at the 5 micrograms per kilogram per minute, and we're going to titrate it up to effect all the way up to 32 drops a minute, which is going to give us our 10 micrograms. So you just take that 16 and multiply it by 2, and that's your maximum drop per minute rate. We're going to take their blood pressure every 2 minutes while we're doing this titration until we reach a desired BP, and then we're going to stop that drip right there, and we don't want to give them any more. And by stop, I mean we're not going to increase the drip rate. We're still going to continue it at that rate. And then we're going to reassess their blood pressure every 5 minutes. If their blood pressure skyrockets from there, we need to back off that drip rate a little bit. Now we're going to discuss acid-base balance and acid-base disorders. Understanding acid-base balance is relevant to understand our sepsis patients because our septic patients are going to present as acidotic. So the body has a tremendous capability to maintain homeostasis. We maintain glucose levels, we maintain temperature, we maintain oxygenation levels and respiratory rates. Another thing that we maintain is a pH, and our body's normal pH is 7.35 to 7.45. So if you notice, 7 is neutral, so our bodies are naturally slightly alkalotic. The way that the pH works, it stands for power of hydrogen. So at 7, there's a fixed amount of hydrogen atoms. If we were to decrease by one whole number down to 6, there's going to be a 10-fold increase in the amount of hydrogen atoms present. If again we were to move from 6 to 5, one whole number, there's going to be a 10-fold increase from 6 to 5. So from 7 to 5, there is a 100-fold increase. So that's what pH stands for, the power of hydrogen. Now, simply stated, all living organisms require water to live. So as the water, is created in our body disassociates it into hydrogen plus cations, which are acidic, and oxide anions, which are basic. And our body regulates the level of alkalicity or acidity with different mechanisms. So the most immediate one is going to be the buffer system. We learned about this in paramedic class, and the buffer system is instantaneous. It's going to be followed by the respiratory system, and the respiratory system's onset is from minutes to hours, and then finally it's going to be mitigated by the renal system, and the onset for that is hours to days. So here we have the buffer system, and the buffer system is an instantaneous process in our body, and normal metabolism creates H2O and CO2. So normally we excrete excess H2O, through the urinary system, and we breathe off excess CO2, through respirations, and we read that as end-tidal CO2. But what our body wants to do, it wants to create bicarbonate atoms so it can absorb excess hydrogen in the body. So what we have here on the left, we have CO2 and H2O, and together those are going to form carbonic acid. That's what we have in the middle here, the H2CO3. Now this carbonic acid, this is really the intermediary of the buffer system. It can instantaneously transform excess hydrogen ions with bicarbonate back into water and CO2, which we're going to breathe off, and the excess H2O, which we're going to eliminate off through urination. And if we have too low hydrogen, like if we're too alkalotic, the body can take this carbonic acid and really break it down into hydrogen plus ions to bring our level of acidity back to normal, our pH back to normal. So this buffer system is really an intermediary, and it's instantaneous, and it helps maintain our pH. Alright, now we're going to talk about the respiratory mechanism for maintaining our pH. And the onset of this is minutes to hours. So as the body becomes more acidotic, excess hydrogen ions are present. So the body converts these excess hydrogen ions with the bicarbonate, the HCO3, back to CO2 and H2O. So these elevated levels of CO2 is what stimulates our respiratory drive to breathe. So we have these chemoreceptors that read the level of carbon dioxide in our blood, and that's what's telling us to breathe faster or to breathe slower. So at this point, some of you guys might be thinking, wait a minute, if they're acidotic, my body converts hydrogen into CO2, and these elevated CO2 levels is what stimulates our body's respiratory drive, then why is an acidotic patient have a low end-tidal CO2? Well, the answer to that is because we only have a fixed amount of bicarbonate in our blood. So after normal metabolism, our body converts those products of metabolism into hydrogen plus ions and carbonate ions, right? So normally our body urinates off the excess hydrogen ions and it retains the carbonate ions. But as we become acidotic, we use up our excess carbonate stores. So the HCO3 becomes used up, and now we cannot convert it back into CO2. And with decreased perfusion in an acidotic state, those products of metabolism, those normal products, CO2 and H2O, if we have decreased perfusion, we have decreased metabolism, and we're going to start creating things like lactic acid instead of CO2 and H2O. So we start to see a decrease in our overall CO2 levels. So a low end-tidal CO2 is really like the end result of an acidotic state. Okay, so now we got the renal system, and this onset for this is hours to days, so this is really a long-term fix. As the body produces excess hydrogen ions, those hydrogen ions are going to be excreted through the urinary system. So the renal system takes those hydrogen ions and it combines them with nitrate, and it urinates them off, and it retains the HCO3, the carbonate ions, for later use to absorb excess hydrogen ions. Okay, so this is in a healthy renal system. So this is why we have issues with patients with renal disease, because they can't excrete the hydrogen and they can't retain the carbonate. All right, so kidney disease limits the body's ability to maintain their level of pH, which is why these patients always have to go to dialysis, and they have a lot of long-term chronic issues. We talked about the pH system and our body's mechanisms for maintaining homeostasis with their levels of pH. But we didn't talk about any of the specific disorders. So we're all familiar with a lot of these. We got metabolic acidosis and metabolic alkalosis, and we have respiratory acidosis, and we have respiratory alkalosis. To further complicate things, we could have any of these conditions as compensated, uncompensated, partially compensated, or mixed. So really, we're going to do a down and dirty, explanation of what these things are. So we're going to begin with levels of compensation because I feel like just understanding this is fairly straightforward. So we discussed the body compensates via the methods of the buffer system, the respiratory system, and the renal system. Now we're not truly going to be able to understand at what level of compensation our patients are at because that requires testing that frankly is not available in the pre-hospital environment, and it's not practical for us to be doing that. However, through careful medical examination and vital sign analysis, we can determine that our patient is in an acid state, and we can apply medical interventions as needed. So the first one is going to be uncompensated. And an uncompensated acidosis or alkalosis is typically new or fast onset. So the body falls outside the range of the pH scale, and the body has not begun to compensate, or the body is unable to compensate. An example of a patient being unable to compensate is a metabolic acidosis in the presence of COPD and renal disease. So if you remember those buffer systems we talked about, once that buffer system, the carbonate, runs out, the body's going to try and compensate with, blowing off excess CO2. However, a COPDer, those chemoreceptors, they're not going to analyze, they're not looking for end-tidal, they're looking for oxygen. So an increase in CO2 is not going to trigger a COPDer to increase their respiratory rate. And if they have renal disease, they might have issues excreting the hydrogen ions and retaining carbonate ions. So this would be an example of a patient not being able to compensate. So, or it just could, like I said, it could be a new onset as well. Next is compensated. So compensated, the patient has an underlying pH disturbance, but the body's response mechanism is maintaining pH within a normal range. So we have uncompensated. There's an underlying disturbance, and the body is not doing anything to try and compensate yet. Compensated is when the body is maintaining that disturbance and it's maintaining the pH. Partially compensated. This is exactly the same as compensated, but the pH falls outside of the normal limits. So, we may have a metabolic acidosis that falls outside of the pH range, and the patient's presenting with respiratory alkalosis. It's not compensated because the pH is outside the normal limits. It's partially compensated because it falls outside of that. And finally, a mixed disturbance. This would be the presence of both a respiratory metabolic acidosis and respiratory acidosis, or mixed metabolic alkalosis and a respiratory alkalosis. Typically with a metabolic disturbance, the body compensates with the opposing respiratory disturbance or vice versa. So if you look here, we have metabolic acidosis compensated with a respiratory alkalosis, or metabolic alkalosis compensated with a respiratory acidosis. Mixed is that metabolic acidosis with a respiratory acidosis. So now we're going to talk a little bit about the actual disturbances, and first we'll address the metabolic disturbances. So the first one I have here is metabolic acidosis, and this is a result of elevated hydrogen ions in the blood. Causes can include DKA, lactic acidosis, hyperkalemia, that's elevated potassium, so this is going to be typically a result of renal disease, dialysis patients, and naturally renal disease is one of our causes, and a tricyclic antidepressant overdose. Signs and symptoms for metabolic acidosis include nausea, vomiting, and weakness. And all shocks lead to metabolic acidosis. If you think about what shock is, and we're talking about septic shock for this lecture today primarily, shock is hypoperfusion, so we're not getting oxygen at the cellular level. So oxygen is required for efficient metabolism, and if we're not metabolizing appropriately, then we're not going to be creating the appropriate byproducts for our body to utilize to help mitigate our pH levels. So shocks are going to lead to an acidosis. And it's going to present with low end tidal CO2 as well, because as the body runs out of these bicarbonate ions to buffer this excess hydrogen, then we're going to end up having a lower amount of CO2 in our readings. So moving on to metabolic alkalosis, this is going to be a decreased hydrogen ions in the blood and increased bicarbonate. So causes include massive vomiting and or diarrhea, hypokalemia, which is going to be low potassium, or excessive ingestion of antacids. So someone that's got GI or not GI acid reflux issues, if they take too many antacids, that can actually bring them into a metabolic alkalosis state. So signs and symptoms for this are going to be nausea, vomiting, headache, chest pain, lethargy, muscle spasms, and potentially seizure. Now we have respiratory acidosis, and this is primarily caused by respiratory issues resulting in elevated CO2 retention. So one of the biggest things for this is going to be COPD, because they have increased issues with blowing off their CO2. Overdose is another classic sign for respiratory acidosis, and obesity. Obesity, they're not going to really be able to increase their minute volume to blow off excess carbon dioxide, so they're just decreased respiratory effort over time is going to lead to respiratory acidosis. So treatment primarily revolves around restoring adequate minute ventilation. So just BVM them if you need to. Really encourage them to take deep breaths and move some air. Respiratory alkalosis. This is primarily caused by psychogenic issues. So by that I mean think of a panic attack. But this could also be the result of an underlying issue requiring more O2 and thus more CO2 blow-off as a result of that. So think about a pulmonary embolism. So imagine if we paper bagged a pulmonary embolism patient. They're not getting oxygen and then just going to be rebreathing their CO2. That would be catastrophic for them. So that's why we don't treat panic attacks with a paper bag. So those are going to lead to respiratory alkalosis, and treatment primarily involves addressing the underlying cause. Okay, so now we're moving on to capnography. Some people call this the king of vital signs. I really enjoy capnography because I feel like it can tell us a lot. And even if we don't quite know how to analyze it, which what this section is all about, it is still beneficial for us. So think about your overdose patient that's like altered and they keep passing out. If you throw some capnography on them, you can really monitor their respirations just fine. And if their breathing rate is fine and their levels are within the normal limits, then you know that their respirations are adequate. You don't necessarily need to be fighting them to keep them up all the time. And again, let's say we have a seizure patient, and you're concerned that if they start seizing, have they stop breathing? If you got some capnography on them, you could tell. So this is what a normal waveform looks like, and the normal rate is between 35 and 45. So here are some common patterns of waveforms that we may see when we're monitoring a patient's capnography. On the top left, we have hypoventilation. It's going to be hypoventilation if the respiratory rate is slow and that we have elevated levels of CO2. What's happening is the patient is not moving enough air, so they're building up this CO2, and that's why we're reading an elevated rate in our capnography. So the solution to this would be to increase their minute ventilation and to bring their end tidal back down to normal range and make sure that their rate is good. Now another thing about this hypoventilation, this would be a respiratory acidosis. However, this could be a compensation for metabolic alkalosis. Remember, we talked about how the metabolic disturbance is going to be compensated with the opposing respiratory disturbance. So here it's very important that we have a medical history and we've done an examination on our patient. Maybe our patient had chronic diarrhea, nausea, vomiting, or maybe they were having really bad gastric ulcers or whatever. They were taking a crap ton of antacids, and now this is what we have. So that would be something that would cue you in to think, hey, maybe they're metabolic alkalosis, and this is a compensation. All right, so moving down, the next one we're going to have is hyperventilation. Now this is going to be like those panic attacks that we're talking about, those psychogenic causes, or this could be like a PA. So this is going to be representative of a respiratory alkalosis. So they're breathing super fast and they're blowing off all their CO2 which is why we're seeing a lower rate. Now again, this could be a compensation for metabolic acidosis. So doing our medical exam and we think that our patient potentially, is septic, or they have some sort of distributive shock, or they have, renal disease, and there's some issues going on there, and they meet the criteria for us to suspect that they're potentially in a metabolic acidosis, and we see this, they got an elevated respiratory rate with a decreased end-tidal CO2, that's a respiratory alkalosis, and that's a classic sign of a metabolic acidosis patient. So moving down again, we have rebreathing. And what's happening here is the patient is not having a full exhalation. So normally as you breathe in X amount of air, you breathe out, a proportional amount of air. We have this normal exchange between oxygen with our inhalations and carbon dioxide with our exhalations. So what happens if we don't finish our exhalations? We don't exhale all that carbon dioxide, so we're going to see this stacking where these boxes for our capnography waveforms are going to just get, it's going to go higher and higher and higher like a staircase. So that's what stacking is, and that's what's happening. So moving on to the top right, we are all familiar with the shark fins. And what's happening here is we're showing you this presentation because the patient is having a prolonged exhalation. So looking back at that rebreathing, you can look at the top of those waveforms, how they're relatively flat. That is exhalation, and that's a normal presentation. That's what the expiratory phase is. Looking at these shark fins, that what was flat has now been slanted down towards the left, and that is a prolonged gradual exhalation of CO2. So a little bit's coming out, and as you keep breathing, more and more and more and more comes out. It's not all coming out at once, and that's why we're presenting with the shark fin. So this is going to be very indicative of bronchoconstriction, so our asthmas or our COPDers with exasperation. Now capnography is awesome for a patient that has COPD and CHF. CHF can present with wheezes because as the air moves through the fluid in the lungs, it can cause a wheeze of sorts. So if a patient has both of those illnesses and they're having shortness of breath, it's like, well, is it the COPD or is it the CHF? We don't want to treat the CHF with albuterol. We don't want to give them something that's going to make their heart work harder. So if we place them on capnography and they're showing shark fin waveforms, then hey, they're having a COPD exasperation. I'd get on the horn with medical control and be like, hey, my patient's got CHF and COPD. Capnography shows shark fin waveforms. I want to give them albuterol. And they'll probably say, go ahead. Now in the hospital, they have a different type of respiratory treatment that's not as hard on the heart, so they would probably give that in the ER. So moving down, we got the Curie cleft, and what this Curie cleft is, typically you're going to see this in a intubated patient. So they're exhaling, and then that little dip that you're seeing at the end of the boxes, that's the patient like spontaneously taking a breath on their own. So if you got an intubated patient and you're seeing this, that means you got to give them a little bit more sedation. And finally, on the bottom right, we have what's called cardiac oscillations. And what we're seeing is actually the heart influencing the exhalation of the end tidal at the end there. And this is an ominous sign. So if you see this, this is not artifact. This is something that's not so good. Okay, now that we discussed waveforms, I want to talk about imbalances with our capnography and our respirations. Pictured on the right is what we call a normal VQ ratio. So V stands for ventilations and Q stands for perfusion. So if you're ventilating normal and you're perfusing normal, you have a normal VQ ratio. That's just the terminology that they use. So if you place your patient on capnography and their respiratory rate's 14 and their end tidal's 40, you can assume, as long as nothing else is going on and your patient seems stable, that they're not currently experiencing any cardiovascular, metabolic, or respiratory issues. So capnography is the king of vital signs because it can really give you a good, quick assessment of what's going on. So here is where we have a hyperventilation or hypoventilation mismatch. And we're going to have, either severely elevated respirations or severely compromised slow respirations. They're not just elevated or decreased like a little bit, they're pathologically so, like in a way that's not sustainable for life. So think about a pulmonary embolism patient. Like they're breathing so fast because their body just needs oxygen, but they're not oxygenating. So what we're going to see on the left here, we have this decreased respiratory rate and this decreased end tidal, or increased respiratory rate, decreased end tidal. Or think about our opiate overdose that goes into pretty much respiratory distress or rest, where they're just agonal respirations. You're going to have this decreased respiratory rate, and they're going to be retaining their end tidal CO2. So this is what a hyperventilation or hypoventilation mismatch is. Another one of these would be diabetic ketoacidosis. You're going to have a underlying metabolic issue that is life-threatening, and you have these deep, rapid respirations with a decreased end tidal CO2. So if you see, these just significantly out of balanced ventilation and end tidal readings, it should really cue you into something is, critically wrong here. Now, the one exception to this that I would say would be like a psychogenic cause, like a panic attack. So really here, we need to focus on calming the patient down. Not to say that psychogenic causes can't become critical, but if we can just calm them down, we can really tend to improve their symptoms there. Now, what we're showing here is a circulatory or metabolic mismatch, and we're going to have relatively normal respirations with decreased end tidal or increased end tidal. Now, when I say relatively normal, I mean that it's a respiratory rate that, if that's their only thing that's going on and nothing else, is bothering them, we might say, what, we're concerned about this, but this is not life-threatening. However, if we combine that with decreased or increased end tidal readings, it's indicative of something going on. So they're potentially going into a shock state, or they're in shock with a acidosis of some kind. So I would like to look at the metabolic mismatch here on the left, where we have a normal respiratory rate with a decreased end tidal. That's something that I would expect to see potentially with a septic patient. Maybe their respirations are like at 20, and it's kind of on the high end, and their end tidal is low. That should cue you into that something's going on. Or vice versa, if their end tidal is high, it should cue you that something here is not quite right. So altered end tidal CO2 readings without pathogenic respirations are indicated with metabolic or circulatory issues. Consider causes of metabolic acidosis or alkalosis, and that again brings us back to our medical examination. Compensated hypovolemic shock, sepsis, cardiogenic shock, all these things could lead to these types of mismatches. Low end tidal is a little more ominous than high. High could be associated with COPD. Again, assess for underlying causes. So these capnography resources that I have in this PowerPoint slide all come from this book, Capnography, the King of ABCs. This is a very short book. It's probably only 50 pages of actual material. A lot of the pages in there are reference pages and things like that, and there's a lot of pictures. It's a very quick read. You can probably get it done in an hour or two. This book is actually scanned in the Common Drive. If you were to go into the Common Drive and search critical care, a folder will come up, and it's going to have this book and other resources in there. I would definitely recommend this book to anybody that wants to know more about capnography. What we cover today is really just the scratching of the surface. So I would definitely recommend this book. Now, last slide, putting it all together. SIRS, Systemic Inflammatory Response Syndrome. The patient may or may not be septic. Septic is our patient meets SIRS criteria plus a known or likely infection. Severe sepsis or worse. They're likely to have an acid-base disorder, metabolic acidosis with low end tidal CO2. So here is what we're going to be looking at this circulatory metabolic mismatch. Okay? And a thorough medical exam and history combined with vital signs and capnography can identify the probability of sepsis, allowing us to activate the appropriate response and increase survivability. And at the end of the day, that's what we're here to do. We're here to take care of our patients and give them the best chance to live that we can.